So then after this, we moved to something interesting about shockwave lithotripsy, because this session is on new topics in vascular medicine. Okay, so we have two lectures here. I would be talking about the concepts, and then Dr. Raj Pratap is going to be showing his case about EVL in peripheral vascular disease. So this is shockwave lithotripsy is a new tool in our armamentarium. The presence of calcium indicates worse prognosis. We have seen Dr. Deepak Jain actually presenting a lot of complications, how to deal with a lot of complications of coronary perforations. And many a times in coronaries and also more in peripheries, this calcification indicates worse prognosis because this has been experienced by most of the vascular interventionalists. The intraarterial calcium is associated with higher rates of angiographic complications like dissections, perforations, slow flow, no flow, distal embolization, and recoil. And especially now, like Dr. Henry said, gave a lecture on DEBs, and DEBs also require, the calcium is not a great, welcome thing there, and we need to really dilate these vessels well and prepare the vascular bed to actually deliver the drug. Heavily calcified arteries are difficult to dilate with conventional balloon, and they often require mechanical debulking or plug modification with atherectomies, which could be laser atherectomies or rotational atherectomies or directional atherectomies, and sometimes rotational atherectomies or orbital atherectomies. They do provide acute gain by affecting superficial calcium, but again, the deeper calcium is not affected by these atherectomy devices. So there was a need that we have a different tool to actually take care of both superficial and deeper calcium. And we all knew that lithotripsy for last 30 years has been working on very calcified stones in the urinary tract. And that technique was miniaturized on a catheter-based system. And this has a miniaturized and arrayed lithotripsy emitters for localized lithotripsy at the site of vascular calcium. So it took about 2 decades to actually miniaturize the same technology. And then we came up with catheters, both for coronary and peripheral use for tackling difficult calcium in these vascular beds. So if you look at the machine, it has 3 components. It has a console, which is battery operated. Then it has a sort of a catheter, which delivers and it has a switch for giving lithotripsy. And then we have a catheter, which is dedicated for coronary or peripheral use, depending on where we are using. It comes in different sizes. These are the OCT pictures in coronary and peripheral arteries, which shows that this disrupts the calcium in not only the superficial calcium, but also the medial and the deeper calcium. Now, we have 2 sets of catheters for use in peripheral arteries. I'm not talking of coronaries. For peripheral arteries, we have a set of catheter which is used basically for below-knee lesions. That comes in 3.5 to 4 millimeter in diameter. And for popliteal, we have diameters from 3.5 to 6. And for iliacs, we have diameters from 6.5 to 7. The lengths of catheter which we have, I'm talking of the balloon which has emitters for lithotripsy, are 60 millimeter in larger diameters and 40 millimeter in lower diameters. The maximum pulse count is 300 in larger catheters and longer catheters, and 160 in the shorter catheters. They all go through 014 wire, and they are the smaller ones are compatible with 5 French system, and the larger ones are compatible with 6 and 7 French system, and they have a working length between 110 to 135 centimeter. Now, how it works, it's a novel calcium modification tool that uses sonic energy waves to modify both intimal and medial calcium. And the calcium modification by shockwave lithotripsy actually leads to miniaturized, it generates shock waves characterized by short durations of 5 microseconds and positive peaks of about 50 atmosphere and negative troughs of the same magnitude. A contrast-filled balloon is inflated just to oppose at suboptimal pressures to just oppose these emitters to the vessel wall. And there is an axial splitting of compressive circumferential forces. It generates violent collapse of cavitation bubbles by shock wave inside the saline-filled balloon which impact the surface of the calcium. And there is a fatigue mechanism involving the progressive expansion of microfractures into macrofractures, and this leads to fragmentation and fracture of the calcium. Now, this hypothesis was tested in the lab and then on the animal models and then in the human trials. And we had 4 trials, the Disrupt PAD 1 and 2 trials, Disrupt PAD 3 trial, and then we have an observational study of Disrupt PAD 3 registry, which is a multicentric registry, and it's a single-arm registry. The initial trials and even all the Disrupt trials actually included patients with heavy calcification, more than 50% of circumference, and mostly the lesions were in long lengths, and often they were also eccentric or concentric, both. Initial studies were of 35 and 60 patients, then PAD 3 had 200 patients, and PAD 3 observational study has 118 patients. And if you look at the acute gain, there was an acute gain of 3.4 millimeter in PAD 3 study, and 30-day major adverse events was 0% in PAD 1, 1.7% in PAD 2, and 6 months major adverse events was 0% in PAD 1 and 1.7% in PAD 2. Now, if you look at the Disrupt PAD 1 and 2 and Disrupt PAD 3 studies, what we see here that in Disrupt PAD 1, we had majority, 3/4 were SFA lesions and 25% were popliteal lesions. While in Disrupt PAD 3, we also included iliac lesions and common femoral artery lesions. And you see here, varying complexity of lesions were used, long lengths, heavy calcification was enrolled in these studies, but there was some limitation of the trials. The biggest limitation is that it's an observational single-arm study without a control group, and there is no definitive comparison that can be made to other interventional devices in terms of safety and effectiveness, especially atherectomies. Only acute procedure results are reported in this study, and PAD 3 RCT will follow subjects to 2 years, and this will provide data on long-term safety and effectiveness of IVL. Infrapopliteal lesions treated in this cohort were too few to analyze, so the study did not have power to analyze and come out with an effective conclusion. Now, let me show you this case. This was the first case of peripheral EVL done in our country. A 70-year-old male who had a bypass in the past, had unstable angina, and this patient had left ventricular dysfunction, also had severe buttock claudication. His venous grafts were occluded and had a native triple vessel disease. So this patient actually required, also in LVF, required a balloon pump to support the angioplasty of this procedure. And when we did the angio, he had a very bad calcified aorta, and especially the iliac arteries, and we had to then resort to dilating this lesion and putting in a balloon pump, but this lesion was not amenable was not giving way on high pressure balloon dilatation. So what we did was we got this IVL catheter. This was a 7 millimeter IVL catheter which we used, and here what we do is we just expand the balloon to a size which just is occlusive to the lumen, and then the shock waves are given in multiple cycles, and slowly the balloon expands and this calcium fractures. And then this was amenable to balloon dilatation and putting in a stent, as you can see on the next picture. And we were able to put in a stent and secure an excess, put a balloon pump, and complete our angioplasty procedure. If you look at it, this is how it looks like. You need to press the button and there is a shock wave which comes. This actually is very hard on the hard surfaces and very soft on the soft surfaces. If you see, I put my hand there, and once we emit this, it does not injure anything, but if you keep a chalk or if you keep it in the calcium, it just disrupts and cracks that calcium. So this is a safe device. So in conclusion, it's an attractive modality for treatment of severely calcified lesions, combining calcium disrupting capability of lithotripsy with familiarity of balloon catheters. Clinical studies support the effectiveness of IVL in inducing circumferential fractures in calcific plaques, and this leads to significant luminal gain, and it facilitates optimal stent expansion. And this may also be a good tool to treat vessels, especially long lesions in infrapopliteal, popliteal, and SFA lesions, where we are trying to do good dilatation atherectomy and follow it up with drug delivery by drug-coated balloon. Ongoing clinical studies will add further insights into the safety and effectiveness of these techniques, but it does help in acute situation, and there are some unique applications where it can be used. It is a good tool, and maybe a good tool to use in no stent zones. That means the flexing areas of the lower limb vessels, which could be popliteal or iliac bifurcation, femoral bifurcation, or popliteal bifurcation. It could be used in high-risk situations like bifurcation, where the runoff is only single vessel, where we are, even when we are doing a subintimal angioplasty, it has proved to be very good, and in failed peripheral angioplasty. Now, patients who are not appropriate for surgery, IVL may provide a safe, effective, non-surgical option for such patients to facilitate angioplasty. And so IVL has a proven role in treating calcific iliofemoral disease. It has a proven role now in facilitating vascular access for large bore devices, both for transcatheter aortic valve replacement and even larger bore devices for doing EVARs and TVARs in heavily calcified prohibitive transfemoral access. So this is one of the star indications where we are using, but it can also be used in no stent zones, in long lesions, calcified undilatable lesions, and in lesions where we want to do drug-coated balloon therapy and the lesions are not giving way and the vessels are not being prepped up properly with conventional balloons. So I'll end here, and I'll invite the next speaker, Dr. Raj Pratap, to show his case, and then we can have a discussion in the end.